Hi, this is Angela. Can you hear me?
Yes.
Yeah.
Okay, so maybe I'll start with a brief intro and just go through some of the ground rules as well. So good evening, everyone. For this evening's seminar, we'll have two presentations on communities at risk and specifically individuals who experience homelessness and drug addiction. So our first speaker is Dr. Dave Jimenez, and he is the Director of Community Outreach Intervention Projects, or COIP. And COIP is a program of UIC School of Public Health that was developed to promote community-based interventions to prevent the spread of infectious diseases, especially those that are associated with substance abuse. And so COIP's interventions are known for their use of the Indigenous Leader Outreach model, which employs people from the communities it serves to better deliver the services and assist in conducting research. And so during the COVID-19 pandemic, COIP's experts have been using their intervention model to help combat the spread of COVID-19. And Dr. Jimenez will be joined by Edgar Gutierrez, who is COIP's COVID outreach coordinator. So I wanted to remind students to please post your questions in the chat as we go through the presentations. And as usual, allocate some time at the end of the presentation to address the questions. And Dr. Jimenez, if this approach is okay with you, or are you okay with people or pausing throughout the presentation to address questions?
Maybe we could wait till the end, because it may make more sense. People may get a response as the presentation continues to be able to get an answer that they're looking for.
Okay, that sounds good. So we'll monitor the questions in the chat. So I'll pass it over to you for tonight's presentations. Thank you very much for being here.
Sure. Well, thank you for having me to talk about the work that we're doing. And thank you to Dr. Forrest for inviting me, and glad to be presenting with Edgar, who's a colleague here, and Marcus Betts, who I know from all of his great work that he's been doing here at the university, and the work we've been doing collaboratively to address COVID. As you said, you pretty much gave away my first several slides, but I'll go through them anyway. What I'm going to talk about is the work, a little bit about COIP's background, and then the work that we done that laid the foundations for an AbbVie COVID-19 foundation grant that we applied for right at early on in the epidemic, back in late March, and we received funding for it in April. And I'll tell you a little bit more about that as we proceed with my presentation. But basically, I am the Director of Community Outreach Intervention Projects, or our acronym, we go by COIP. It was formally founded in 1987. I got hired by Dr. Wayne Weibel. Back then, I'm a staff member who's been with the project since its founding. And I work as I'm a trained ethnographer doing qualitative research in communities around the city and Cook County. And actually, I've done work outside of the state and other parts of the state. But anyway, I was asked to work with COIP by Wayne Weibel, who's the founder of COIP, and originally came on board with one of his NADAR grant, which was one of 5 that was funded from the National Institute on Drug Abuse back in 1987. Wayne was an ethnographer as well. We all were trained at Northwestern University, Department of Sociology. Ethnography is a kind of particularly useful, unique method of collecting data and understanding populations using qualitative methods. Our first intervention that was funded through this this NADAR grant is the acronym for it. The goal of it was to evaluate the extent of HIV infection among persons who inject drugs and who are on the street, not in drug treatment. And our goal was to deliver and evaluate an intervention. The problems at that time for folks, when we began our work, the HIV epidemic was shifting. Initially had been in MSM gay populations, but they were beginning to see increases among injection drug using populations. And the problems that we were confronting were how to access folks who technically don't want to be found because they're involved in illicit drug use behaviors. And the second challenge was, how do you motivate people to adopt healthier behaviors when they distrust mainstream agencies, organizations, clinics, etc. And so Wayne actually developed this model called the Indigenous Outreach Model to respond to these challenges. And I'll just tell you the main hallmarks of the model. We hire folks from the target population. And in the case that we were working in, we hired ex-injectors to provide the intervention. And the attributes or the qualities of those folks were that they have access to the folks we wanted to engage. They have shared experience, and so they're credible and empathetic to the folks we were trying to reach. And their ability to provide services, intervention services, were enhanced by the fact that they're valued and trusted by the community. Another hallmark or approach of the model was that we targeted the social networks. And the goal there was to change group norms to support HIV risk reduction measures, and to do this over a long term by staying within a community area for a period targeting this intervention. And our model combined epidemiology and ethnographic methods to implement the intervention and guided it as it was progressing over the 5-year period that we were funding. At the beginning, we had 3 field stations in the city of Chicago, one on the south side in Grand Boulevard, one on the north side in Uptown, and one in Westtown, Humboldt Park area. And let me tell you, this is 1987, so these neighborhoods have all become gentrified pretty much now. But back then when we started doing this work, they were very marginalized communities, maybe beginning to change, but not there yet, with a very active street scene. The outreach staff that we hired that were ex-injectors not only worked the streets, but they built relationships with providers in the community. Key among them were drug treatment providers. They basically developed a lot of connections and inroads with agencies and hospitals that often didn't want to deal with drug users or people who were positive. So it was really crucial work early on that these workers did. I just have some real quick pictures here of the nature of the work, the nature of the community. Here's 2 of our early outreach workers doing a lot of our work back then in these communities was in abandoned buildings were, predominant in a number of these communities as they were changing and transforming before they became gentrified. So buildings like this were places where substance users typically would gather and need to inject drugs. They're private spaces, unregulated, so people could go in there and kind of get off on their drug use. And so we would go in there and leave materials or engage people. These were, again, typical scenarios where we do our outreach: alleyways, garages, basically places where people would, we could typically find folks that inject drugs. And so we would focus on those areas, as I said a minute ago, to provide our intervention materials and services. Also occurred in people's homes where they allowed us to come in and do some risk reduction education and instruction on how to. Back then, there weren't syringe exchange early on. We were doing bleach, handing out bleach and water, and the bleach was to clean up syringes, and then water to rinse out the bleach. And so there were very basic intervention tools and materials and messages they were giving back then that were very effective. Let me just say quickly, when we began, HIV prevalence was incredibly high. I was at ethnographer at the northwest side, the Humboldt Park site, and basically 1 in 3 people roughly that we encountered were HIV positive. This was at the baseline. And we, for the whole study, we recruited roughly 800 folks. Out of my field site, I think we recruited, if I recall, about 250 participants. The other 2 sites in Grand Boulevard and in Uptown had a similarly, not as high, but kind of astoundingly high HIV prevalence. And what was noteworthy is we were reaching a population that clearly was at risk, and the prevalence was two times greater than estimates that were being obtained from people that were actively in drug treatment programs. And just quickly, this is kind of a slide that represents the impact of our intervention that we saw over the 2.5-year period, a drop in HIV infections that kind of mirror a drop in injection risk behaviors that people were experiencing. I believe, we strongly believe, as a result of our outreach intervention efforts in using indigenous staff, using targeted intervention methods on a daily basis. So since that time, early on, our model got replicated across the country and around the world, actually, and we became recognized as a model program by various entities that you see there. We also, since that time, we also have developed we continue to do a lot of research around substance using populations, and if you're interested in that, you could always reach out to me separate from this, and I can talk with you about different initiatives that we do here at COIP to conduct public health research among substance using populations. But I always like to kind of highlight the service programs, because we do a lot of service in these communities. We have HIV, HCV targeted testing program that's reaching injection drug users and men who have sex with men. We have a recovery support service program targeting folks who use substances and are at risk for overdose. We have a hepatitis C case management service program, again, reaching mainly a drug injection population, folks that are at high risk for hep C infection. We have funding from the Chicago Department of Public Health to provide harm reduction services for persons who use drugs, and that basically funds a syringe exchange program that runs at 3 sites and on a mobile van, and also provides naloxone and overdose prevention education among persons who are at risk for overdose as a result of opioid use. We have a collaboration grant with the College of Medicine and the College of Nursing through the Hearst Foundation to provide primary care to these populations. And we have, as I said, opioid crisis overdose prevention services. We've been in the news. There's been some articles about the work we've done. And I guess what I'm going to spend the rest of this time quickly talking about is our AbbVie COVID-19 grant. That grant really came about as a result of observations that I was doing in the field. So when the pandemic hit and the school was put on lockdown, we maintain our field stations open, a couple of days a week with really skeletal staff, because we believe that our services are essential for the populations that we reach. And really early on, the first weeks we were doing this, and I was deployed to our busiest site on the west side, and noticed that people were still out. My neighborhood, I live up in Edgewater, and it was empty. People were following kind of the guidelines or guidances that were being issued then about staying home and staying indoors. But coming out to the west side, I realized people were out there. And so I ended up kind of, just making some observations about that. These are typical corner scenes of people hanging out. And from the work that we do, I knew some of these spaces were places where people there's an underground kind of economy going on, where people are kind of exchanging things that they need. A lot of it's around drug markets, but there's other things too that people exchange. And I was noticing a lot of this behavior was happening, this gathering was happening at these places, as well as just in the general community. People standing on corners. And it just was alarming to me, because I thought maybe people don't realize what the risk is here because information hasn't gone out here yet. Early on, the idea was that it was, it was coming from, you hear about China, but I believe early on we were talking about Europe. And the first cases that were showing up in the Chicago area were along the North Shore. And exclusively, mainly among white folks. And I think there was maybe one Asian person that was the first index case here in the city of Chicago. So I was believing too that people were thinking maybe we're not at risk. And so it was a concern to me. And I remember early on talking with Dean Giles and Ron Herschel, Dr. Herschel here in the school. And I was asking, are there any racial ethnic data being gathered about this? Because I think we need to, first of all, see if there is, are people equally at risk in the city based on geography and by race ethnicity. And if not, we can use this information to begin providing some targeted educational messages. This is a drug copying scene. I just happened to be passing by, and that's a little drug dealing area right there. Same thing across the street from one of our field offices. People are hanging out there, and they're just involved in everyday street activities. And again, this is right at the height of the COVID epidemic, or early on. So anyway, our responses were to reach out to kind of larger network, harm reduction network providers, information resources, to receive updated information on COVID and figure out ways to provide this information to people that we worked with. And so we ended up getting some early printed educational information on safer drug use for folks that do inject, some guidance for organizations like ours, and some general information on what to do, like what is symptomology and what you can do about it. And we began to distribute it from our field offices, our field office in Austin, and as well as in the South Side and our North Side location. Right at that time, maybe the third week we were in the field, I decided to apply for an AbbVie grant. I became aware of it, and some colleagues here in the school made me aware of it. And so I applied for the AbbVie grant, the COVID-19 Community Resilience Fund, in early April. I think it was the first week of April. And my goal was to increase my organization's capacity to respond to COVID. At that time, as I said, we were using a skeleton crew to do this work. Edgar was out there with me and a couple of my other staff that were willing to do this work. And I thought we needed some additional support, younger folks ideally to do this, because a lot of the folks that we were seeing on the street, a segment of them were younger people. And I thought they may not see themselves at risk. And so I thought, well, yeah, let's hire some younger people as well. And our goal was to hire 3 community members from the areas that we were in that would know the local scene and would be accepted messengers following our Indigenous Leader Outreach model. And the goal was to provide basic information on COVID transmission and how to avoid contracting the disease, to distribute protective face masks and hand sanitizer, and information on how to use them properly, and information on available COVID testing. And we were awarded $66,000 in April. We didn't really begin this activity due to UIC and contract issues and hiring issues until early, I would say mid-June. So I'm going to stop there because I think that's my last slide. I'm going to let Edgar pick up, because he actually helped with this early work and kind of take it out into the street once we got this grant. So let me stop there and let Edgar pick up the presentation with his slides.
Could we put up we sent another set of slides out. Can those be put up on the screen? Awesome. Thank you very much. Hello, everyone. My name is Edgar Gutierrez. I think I'm on the screen. I'm not too sure. Hopefully you guys can see me. Before I go on, I want to get a quick understanding of this class. Is this an undergrad class? Is this a graduate class? Or is this a medical student class? Can somebody answer that? Anybody?
Hi, this was open to the whole university.
Awesome.
And the students that are in the class there are a lot of PharmD students in the College of Pharmacy, both here and in Rockford. And there are students from all over, actually.
Awesome. Okay, thank you very much. Okay, that helps me kind of ground myself as to like what direction or how much information I'll share with you all. So most of our efforts, really hit the pavement in July, right after 4th of July weekend. That was a very interesting time just because people were still kind of like out and about and thinking, you know, they wanted to be, we're not sure how serious they were taking this kind of like this COVID pandemic thing. So it was a good thing it was a good opportunity for us to see what was going on. COIP was definitely at the, and still is, I believe, to this day, at the forefront of all the work, the COVID work that's happening in the community. There's a lot of great work that's happening at a lot of the community agencies, but one of the things that, one of the pluses that came from the work that we were conducting was that we were visiting a lot of our community, our partners. Sorry, I'm looking at the wrong screen. We were visiting a lot of our community partners that we had not actually had the chance to work with, and it gave us an opportunity to see what services were being provided or what services had to be limited based on resources. Going back to Dave's point as far as AbbVie funding, I did some research in the funding, the grantees, and COIP was the only organization of the agencies, out of the 11 agencies that were funded in Chicago for through AbbVie, that was very specific about doing direct COVID outreach. So that kind of blew me away a little bit, because I know that a lot of organizations are doing a lot of great work, and of course our hospital systems are doing amazing work, our essential workers are doing amazing work. But I was really a little bit taken aback by that. We were really learning a lot about what was going on. You know, there weren't many masks, you know, or materials being put out in the community. So that said, that model, the outreach model that we've developed since then, and it's still being tweaked as we go. Our findings are helping guide larger efforts, such as that of the Chicago Cook Workforce Partnership, which will be looking or working with various community partners to conduct very specific COVID outreach and contact tracing work. And there's a link on these slides that people can access in case people want to find out a little bit more about that.
And could I add one point to that? That
Sure.
actually the School of Public Health received a grant from the Chicago Department of Public Health to implement a COVID street outreach project that will hire 27 workers, and we're in the process of training those folks, but they're using a lot of the methods and information that we've developed through this AbbVie grant. That's all. Okay.
So we're very happy and fond of that, that they're looking to, external partners are continuously looking to COIP for various intervention models. A lot of this work includes actively problem solving, both internally as well as externally. Internally, we've had to rely on our sister programs. We have various programs within the organization that we need to rely on as far as resources, as far as staffing, but it also not just forced us, but it significantly nudged us to actively work with external partners or other organizations that were providing services that we were not able to, or that were being requested at the community level. And one thing that was really important was that this wasn't just a job for us. It wasn't just like something that you came in and you clocked in and out of. We were actively looking, even amongst ourselves, we were amongst the staff that were still working in some of the clinics, even though there was a lot of folks that were restricted from being able to work in our sites. We were actively working with other organizations, or even thinking, you know, like thinking outside of the box. We were reaching out to um, other partners, other like Chicago Public Schools. We were looking to other programs. So there was an active networking that seemed to be expedited given everything that was going on with the pandemic. I anchored a link on the bottom of the slides that talks specifically about volunteer opportunities at UIC through the School of Public Health. And if the link doesn't pop up, if you look up UIC SPH COVID volunteer opportunities, you'll get a landing page that will guide you to where you can actually look for some of those opportunities. So some of the areas that we were actively working towards. So when we started doing this, this was back in July. In our planning phases, everything was still kind of like up in the air. There were still things, there were things happening and rolling everywhere. So we mirrored a lot of our work in the communities that we were focused already in, or our primary services were focused on. And at the time, we did not. Right now, you're looking at the Chicago COVID dashboard. This is an interactive dashboard that provides very current COVID information by zip code, and so it gives you testing information. It provides you infection rates, and it provides you mortality information. So we encourage people to visit this dashboard if you've not already, or if you've not seen this dashboard or been encouraged to do this in your current coursework. We strongly recommend that you visit this page. The more active, intuitive minds are looking at this information, the better I think we can respond as a community, as a collective force. So most of our work right now has been focused in West Garfield Park, Austin, Humboldt Park, South Lawndale, and West Lawn and New City. So given the requirements of COVID, CDC guidance, maintain your distance and mask and fear and all this other stuff. Community engagement was significantly challenging. The one thing I didn't put on here that I regret was that our work was significantly impacted by the riots that were occurring in the city. We were on a steady pace doing a lot of this great work, and unfortunately, I'm choking up just thinking of it, so I'm going to try not to even talk too much about it, but the riots just seemed to kind of like significantly impact, and it just added this huge layer of fear and just people being disengaged, but it forced us, or gave us an opportunity to see what that disengagement was. So that all that to say, community engagement was key. We were going into some neighborhoods where folks are not used to people being actively kind of like coming up to you and saying, hi, here I am with this mask. I'm here to provide you these materials. And we knew that we were visitors to these communities, that we weren't just like this service, or you should be grateful for this. It was more kind of like, I would like to provide this service for you. And here in this picture, this is one of the areas, I won't name the area, but in this area, we were very vigilant about what was going on. So we had to engage folks that were consistently there to help give us information as to like where best to provide these materials, or where is the need greater, because even if there's a good number of community partners out there, the true information, the real information of what's going on that's going to put the finger on the pulse of the community is with its residents. So we encourage that there be a systemized manner to engage or have a standard set of questions of what you're looking for to assess the community. And the other element to that is you're going to get buy-in, and that buy-in is very important, because we were a staff of 3 at the time, or there was only 3 of us at the time. Our team is growing right now, but actually, I'm sorry, we were just a 2-man team. And we were all that we had. We were out in the community in a van with materials, with field sites, our field sites scattered throughout the city, and we had to identify ways of making sure that we were safe and that the community was protecting us. So we would engage individuals, we would engage folks. We were in active locations where drug dealing was going on, where types of violence were going on, and that didn't deter us. I grew up in the city of Chicago. I grew up in these environments. Those environments I was very, very familiar with. So it's nothing to me. But when you're a part of a team that doesn't get a chance to kind of like know really the community as well as it is, visit the community, drive through it. Again, in a systemized way. Don't just drive around someone's neighborhood, but you have to be very intentional with the work that you're doing. And we encourage folks to be very active in finding out more about the community. It's not just about looking at the map and seeing what's highlighted on the map. Whether you're looking at COVID rates, HIV rates, poverty rates, homelessness, unemployment, you have to add layers to that, and that's investing in finding out who the stakeholders are, what businesses are there, what services are being provided, what services are not being provided, and lastly and most importantly, what do community residents feel or know about public health or service access. So that's super, super, super important. So, my slides are a little jacked up. My apologies for that. So when we first started doing this, we had no branding. We had no real large plan. We only had our experience, and we had to figure out how to kind of like fold. We didn't know if we were needed to fold that experience into the COVID pandemic or fold in the COVID pandemic into our experience. And it was kind of like it was symbiotic kind of a thing. And we did want to make sure that when we were partnering up with other agencies, that we were branding ourselves, that agencies, that community knew who we are. Well, as long as other communities as well, other community partners knew who we were. It helped distinguish, services between partners. We weren't misrepresenting ourselves, or we were able to mutually refer clients to other services that were in that neighborhood. We were able to establish trust with the community members. If we were there consistently, if they remember this sign, or if they remember our T-shirt. My apologies that I screwed up the slides there. But the last thing that we did was we incorporated our branding, our messaging into our branding. So this behind this slide, there's the other side of the T-shirt. So it offers this information, and then we put on some very COVID-specific language that talks about, act to respond, respond to COVID, act against COVID, do your part, because that's a lot of all the messaging for COVID is follow the behavioral guidelines for COVID. 6 feet distance, wear your mask, no more than at the time I think there was like no more than 10 people in a gathering. So that's some of the evolution of the programming that we did. There we go. Sorry, I should have taken the slide. So in this, we were right when we were starting to hit the field or hit the pavement, we were trying to think about what messaging, and do we have to have, who's going to draw this? I was literally making stick figures out of stuff. But we were reading a lot of articles, and luckily Dr. Jimenez had caught this this image here. Well, this is a variation of the original image, but this came from the New York Times. It was an article that was put out back in March or April. We put the source material on there because we have to follow APA rules. Cite your source. We tweaked up the image, and we added some other language on here, and then we coupled it with our program messaging. So we made flyers. In fact, I'm going to try and put it up. So we developed packaging. We created these little flyers. I hope you guys can see that. I can't see my image. Oh yeah, there you go. We created little flyers. We added a mask in there. We started putting little containers of sanitizer in there that we started creating ourselves at our office, and it works. It works. We're able to, as soon as somebody approaches you, we're able to immediately guide them to this messaging and say, this young lady has her mask on appropriately, while these people do not, and it just gives you a talking point. So it gives you an opportunity to kind of like engage people and educate while you're doing this work. That said, every moment is a teaching moment. We make no assumptions about anyone learning. We couldn't just hand someone a mask. In fact, there were at the beginning, we were just like, oh, here you go, here's this mask for you. And then people would either put it in their pocket or put it on wrong or put it on. So we immediately realized people need to know how to actually put on materials appropriately. So we started standardizing the message, the language amongst our team. We wanted to make sure that residents understood that it wasn't just for our safety, but it was for their safety. We're seeing 100 people every event at the least. So we're exposed to these individuals. And once they hear that, they're just like, oh, like they're reassured. They're reassured that, yeah, I should follow this, and they start using their sanitizer right away. And the other thing that we were finding was that there was a lot of misinformation on COVID practices, on how to keep yourself safe. So we are active in making sure that people understand that we're not just giving them behavioral material, but that we're also giving them opportunities to identify places to go get tested, or to refer them back to their doctor if you're feeling ill. Contact your doctor if you have Medicaid, Medicare insurance. Don't just go to a hospital. So, and that was what, if you guys, if everyone remembers, at the beginning of all this, everybody would just go to the hospital the minute they sneezed, and that flooded our hospital system. So there needed to be this strong messaging of correct information to make sure that we're helping not just our citizens, our residents, but that we were also helping the hospital system. So yeah, that was my point on that. I'm sorry. So we're a very simple crew. We don't have anything fancy. We're literally like just a van, a table, our material, our staff protected. We're documenting information. We're making sure that we're not just giving out material, but we're being very intentional with what we want to know. We've tweaked some of the information that we're collecting so that it's a little bit more engaging. Where we were just collecting out demographic information, now we're being a little bit more intentional. Like, we're asking people, are you getting tested? How many times? If you're not, where would you like to go get tested? How many people are in your household? So we're trying to get a better picture, or make the picture a little bit better. Again, this is going to go through to 2021. God forbid we ever have another, pandemic like this post 2021. But now we have laid out the groundwork in preparation for any future events. God forbid. So our community needs a lot. It goes without saying, our communities already needed a lot prior to the pandemic. Now this thing hit our community. This has elevated exponentially the need for everything. I mean, clothes, food, water. Last Friday, we had somebody walk up to us with shoes that were literally like the sole of the shoe and the shoe itself was just, they weren't even like sticking. The poor man's feet were sticking out of the shoe. So it was very, very important for us to document. We mirrored and we made sure that our documentation was very, very clear about what's needed. And then going back to the slide, the point that I made in the slide earlier about problem solving, community response, networking, at our specific clinics, when we were doing this COVID stuff at the way on, our staff were providing food for our clients walking in. Since then, we've established connections with other vendors like that provide donations, like the Costco Corporation, and they give us donations, and we're able to get it back to the community when someone comes up to us and says, "I'm hungry. Do you have anything to eat?" Which is a shocking thing to hear. If none of you have ever had somebody walk up to you, it's one thing to be hungry. It's another thing to have somebody walk up to you and just say, "I'm hungry. What do you have to eat?" You know, it's dumbfounding to have to be in that situation. And you know, you try to provide everything as best as you can, but it's something that we must proactively respond to, regardless of what program or where we're at. And some of the supportive services that folks have been asking for have been like the simple things. I lost my ID. I don't know where to get it. I don't have insurance. I don't know who to contact for, you know, unemployment. And it's that one simple little engagement, or that one simple little, here's this number or here's this agency. You're not going to solve everyone's problems in that one encounter. We know that. That's a message that I make sure that my team knows, and we constantly check in with each other at the end of the field event, before the new week starts, because it impacts your soul to be in the field and see someone just struggle with all of their, whatever their priorities are, and all you can offer them is like an apple or a bottle of water or a phone number to something. But it's something that they didn't have prior to them getting to you. And that's what you have to kind of like walk away with from that experience. I think that's it for my section. I think we can open the floor up to questions for Dr. Jimenez or myself, if anybody has questions.
Or do you want to wait till Marcus?
Oh, my apologies. I forgot. Yes, please.
Would it be easier maybe to ask the questions directly after the presentation while people, like, the information is still fresh in people's minds?
Okay.
Or did you want to move on?
I would like to suggest going on to Marcus, because I'm a little afraid people are going to leave before his talk.
Okay, sounds good. So our second speaker is Marcus Betts, who currently serves as the Assistant Vice Chancellor for External Engagement at UIC. And in his role, Mr. Betts focuses on elevating and promoting the University of Illinois' hospital and health services system. And he has advised UIC senior leadership on a variety of community matters. He facilitates connections that strengthen and build partnerships while developing and maintaining key relationships with different external stakeholders, associations, corporations, and institutions. And Mr. Betts has also previously led UIC's efforts to host the Obama Presidential Center and worked closely with Obama senior advisors, community organizations, the mayor, and various elected officials. And Mr. Betts, you have a very interesting background in business, so maybe you could also share a little bit more about yourself with us. Thank you for being here.
Oh, you're on mute, Marcus.
Okay. Can you hear me okay now?
Yes.
Yes.
Okay, perfect. Thank you, Angela, for that gracious introduction. I could not have written it any better. And sure, I'll share a little bit about more about my business background. If you go to, am I driving, Angela, or are with the slides, or am? Okay.
You should be able to, advance the slides.
Perfect. So I'll start off. First of all, thank you, Dr. Forrest. Thank you for inviting me to contribute along with my colleague David and and Edgar. I am really excited to be here. I'll tell you, I started off, I said I wouldn't have many slides, and then I ended up sending over 10 or 15 slides earlier today. But as I started to think about this presentation, I think a few things jump out at me. Number one, I love the fact that that you have convened students from all over campus, and I think as you start to talk about and we dive into some of the responses and this pandemic in which we're in the middle of, I think it's important because one of the philosophies, one of the things that we've often talked about is this is an all hands on deck response. It's an all hands on deck, and prior to my role with a strategic focus on our health system, I was actually the senior director of community and corporate relations based on the East Campus. So I've had the luxury of kind of having a sort of a dual lens on campus. I know often we think about UIC as East Campus and West Campus, and oftentimes those worlds are siloed. But prior to UIC, I did work in corporate America. I spent most of my career in business and in sales and marketing. But I've always worked in communities and with community organizations. I think if you ask some folks from my life, they might give me this title as an activist. Which I think is just a person that's on different issues. So I'll dive right into it, and I'll start with an overview here today. Dr. Forrest asked us to talk about the communities at risk during the COVID-19 pandemic. So what I hope to do here today is sort of just start with just discussing some of the issues in which we've encountered. There's been no shortage of things that have required very in-depth discussion and discourse. I'll dive into some of the very, very unique demands, and given the sort of duplicity of the pandemics which we're in right now, given the COVID-19 and the racial pandemic that we're in. And I'll talk a little bit about some of the challenges, the unprecedented challenges that we face today. And then I'll tell you a little bit about what we're doing. Dave and Edgar kind of opened up the discussion with some of the initiatives we are actively involved in. Hopefully I'll be able to, maybe I can give you a little bit more of the background on some of the initiatives that I think everything's interrelated, but I think it might be helpful from a context perspective. And if we've got some time, certainly any questions and answers. So I'll start with the issues, and you'll notice I scratched out issues, and I just issues is when you talk about COVID-19, I thought was a bit soft. These were problems that we were facing. These were deadly problems that we were facing. The biggest problem initially dealt with the death rates or the mortality rates, and that we saw predominantly on the front end in the Black community. Blacks were 7 times more likely to die as a result of contracting the virus. And now what we see now, as many of you know, I'm sure, is now we see in the Latinx community the rates have just they've just soared all over the city, and particularly I think if you look at some of the data in the Northwest communities, we've seen we've seen those case rates just soar. Another problem that we faced here is this issue of trust as it relates to communities. You probably hear folks talk about trust now in sort of the clinical trial vaccinations. There's a lot of discussion around, well, communities don't trust institutions, communities don't trust vaccinations, and this is really an issue that has sort of evolved as we move different phase in responding to COVID-19. And I'd say one of the biggest challenges we faced is around communication and messaging as it relates to COVID-19. So when you think about communications and messaging, everything kind of starts and ends with communicating the impact of this virus, why it's important, why folks should honor and respect the social distancing, limiting the congregate settings. But if you aren't able to communicate that and design proper messaging, then you're sort of shooting in the dark with vital information that you'd like to connect with people in the community. One of the biggest challenges that we faced was around communication with our youth, and as we dive into that, I'll share some stories about just some of the unique challenges that we faced within communicating with our youth, the Gen Zers versus Gen Xers, just all the different layers that kind of emerge as you start to think through these issues and these challenges, these problems. So right off the back, one of the big challenges within the communication sphere was dispelling the myths that existed in the communities. When we started to focus on our initial response, which was predominantly in the African American community, given the mortality rates, the rhetoric that was on social media was just it was ridiculous, and it was actually posed a legitimate problem. We started to understand that some folks actually believe this information that they saw on social media, and perhaps the biggest myth that we saw was that African Americans couldn't get the virus. And I think a lot of that had to do with just the news reports and the way the media reported these challenges. There were many people in the African American community that actually felt that African Americans could not get the virus. Another myth is that young people could not get the virus. Even now we know that that youth are less likely to have some of the underlying conditions that agitate the virus. But we know unequivocally that that youth not only get this virus, but in the second wave of communities that were actually contracting the virus, that wave was in our. And I'll talk a little bit about, give you some specific examples on some of the teams that we worked on and examples that we had to address in dealing with this issue. If you drink warm water, it'll rinse the virus from your throat. Hot hair dryers will kill the virus. The virus was created to harm and control African Americans. These are all ridiculous myths. But from a communications and messaging perspective, these were all things that we had to take very seriously and actually craft myth-busting language to actually put out, to try to dispel the myths that have occurred. So in terms of demands, and this slide should probably be demands and challenges, but these were very, very unique sort of demands in which COVID-19 required us to try to rise up to meet these demands. I'd say one of the big demands around COVID-19 was that we needed to move quickly. We needed to move quickly as a group and with a response. The challenge there is where do you move where? Within these communities, we learned that the virus impacted folks with underlying health conditions, but oftentimes these were elderly people. Once you start dealing with family dynamics, you started dealing with many households where you had essential workers that could not stay home, did not have the luxury or the ability to work from home. These are the challenges that started to emerge. When you start thinking about the various communities that are at the greatest risk, the most vulnerable communities, and sort of how they are able to respond. So move where? Move quickly, but move where? So it's like hitting a moving target is what we found ourselves having to do. Being responsive and empathetic. Our racial equity rapid response team, our strike force, and I'll dive into it. I think that's the next slide. I'll explain what those are. But these are groups that come together to actually work on the COVID-19 response. But a big demand was that we had to be responsive. We had to be responsive and empathetic. One of the biggest challenges that we find in engagement work within communities is that folks often have institutions, researchers, institutions, companies, politicians that come and they really don't think that these institutions, the trust has not historically been there. So oftentimes these responses, this engagement lacks empathy. And then you ask, well, how do you do that? How do you do that? How do you remain responsive and empathetic in the midst of a pandemic when there's uncertainty? And people don't know how much you care. People don't care how much you know until they know how much you care. And as we started to think about some of our more strategic responses, I think that was probably one of the guiding principles that we put out in front. How is this going to be received in our communities? Are we demonstrating sort of the characteristics that show that we care about the people that are on the other end of this? And I'd say the last big demand was that COVID-19 absolutely required institutions, government entities to be agile. Had to move and be able to move quickly and be able to respond in different ways, and sometimes without the information that you might normally be accustomed to having. I'll share a quick story. The Racial Equity Rapid Response Team, which is let's see here. I'm going to go to the Racial Equity Rapid Response Team, and I'll share this story, but I'll explain what it is first. The Racial Equity Rapid Response Team asks, well, what are we doing? What are we doing in response to this initiative? Well, I'm a part of multiple sort of initiatives that are taking place on campus, around campus. Oftentimes, my work requires, and I often operate behind the scenes, but nevertheless, I've been very involved in many of the efforts. Perhaps the most prominent that has probably taken up a lot of our bandwidth here is the Racial Equity Rapid Response Team. This is a team that Mayor Lori Lightfoot put together to to respond to the high mortality rates in the African American community. It's a team that should partner with Westside United, which is a collaborative of health systems. UIC Health is a member of that collaborative, along with Rush, Cook County, Lurie's Children, Sinai, and others. Those are the core groups that make up sort of Westside United. The structure is led by the mayor's office. There's a provider committee, which is predominantly responsible for working with healthcare providers around the city, convening those healthcare providers and bringing that knowledge base to this table as we think about these responses to the COVID-19 pandemic. Data committee, which is probably one of the most important committees, given that most of our responses have been driven by the data. Where are the infections? Where are they trending? What areas? What demographics? So every day we get a data report out from our data committee. The community leaders committee, which is made up of community organizations from around the city. Initially, we started with the communities where within sort of the African American community, we saw the highest mortality rate. So that was Austin, South Shore, Auburn, Gresham were the initial communities. I'm in the Communications and Educations Committee, which myself and Dean Wayne Giles, Dean of the School of Public Health, co-chaired. Now Dean Giles is the co-chair for the Data Committee. So that makes up this racial equity rapid response team. And I'll tell you, I'll put a peg in this because I give the mayor a lot of credit for pulling a team like this together and that actually listens to the community leaders that are a part of this group. One bullet point that's not there. The School of Public Health is actually the official non-governmental public health partner. And that's been critical. Our strike force, our experts, our researchers have been able to have a direct line into really the city's plan for the response to COVID-19. But I'll go back. Why does this matter? Why does a racial equity rapid response team COVID-19 matter? Well, I'll give you an example. The mayor's, the deputy mayor, Human Services, we had a meeting, and one of the things that we talked about was our testing sites. Where should we put testing sites? And this was early on in the process, and testing is still critically important. But where you put testing during that time was probably the most important variable. When you start thinking about access to testing, when you start thinking about the people that you want to be tested, and they went through a map, and they had 0 testing sites on the entire west side of Chicago. 0. And myself and others, we looked at this on the call, and we said, how do we talk about equity when we leave out an entire side of the city of Chicago, which includes Austin, which is the largest community in the city of Chicago. And it was almost like an aha moment where you started to realize that when you start working in communities and you bring different entities to a table, government entities, you have health care providers, you have community folks, you have all these different folks at the table, things slip through the cracks. And oftentimes it's not intentional. In this case, it truly was an oversight. So the deputy mayor left that meeting. She said she went right upstairs to the appropriate office and had that rectified. And within 48 hours, they had a site or plan for a site on the west side of Chicago. And I think, when you talk about being agile and responsive and having empathy, those are some of the the guiding principles for addressing and engaging communities at risk during COVID-19. One other note about the Racial Equity Rapid Response Team. When we started this process, Mayor Lightfoot, she shared with me, she said, I referred to the equity team as a task force. And she said, it's not a task force. I don't need a task force. I need a force. I need a team that can go into our communities, get deep and wide, and act quickly. Act quickly. And this sort of ended up being sort of the mantra, sort of what was what kind of informed our thinking as we move throughout this process, and even as we move into other initiatives that evolved from these efforts. One of those initiatives, and David and Edgar kind of talked a little bit about this, and you all have maybe heard about this from Dr. Force, but the street outreach team is one of the efforts that sort of emerged during this conversation. And I'll give you some origins here. I don't know if any of you recall, there was a time, I believe it was maybe March or maybe early May, when Mayor Lightfoot, you see the article here, she stopped a group of teenagers on the west that were playing basketball in the middle of a pandemic. And she told them, hey, you guys need to stop playing basketball. You need social distance, and it didn't go over so well. In fact, there was quite a bit of criticism and pushback in the media for the way in which the mayor handled this. We ended up, the Racial Equity Rapid Response Team, we ended up having meeting in days after this kind of blew up in the media. And there were talks around, well, what do you do? We have folks that are congregating in and around the city. What do you do in communities that really don't have the education that's needed? Really, many people are aware, but really don't understand the nuances and the real dangers, and really how to protect themselves from this virus. And there were some suggestions that the CPD or the perhaps Chicago Police Department might increase sort of their enforcement of the COVID-19 rules, social distancing rules that were in place. Well, I grew up on the west side of Chicago. I grew up in North Lawndale, and I've had my own experiences with the Chicago Police Department. And immediately I said, listen, as a Black male, I just don't think, typically when you increase Chicago Police Department involvement, that usually doesn't end well for a certain segment of people. And the group agreed. So I said, let's think about an alternative strategy. Let's think about an alternative strategy, right? Because now you have COVID-19, but when you're dealing in the community, it's deep into vulnerable communities, and you're talking about there's a lot of different things that come into play. Now you're talking about sort of exponentially increasing the risks that are involved in just being within those communities. So I ended up presenting the group with what I called an alternative strategy to increasing CPD COVID-19 enforcement in priority communities. And the idea would be to focus on our heavy traffic areas, especially during nice weather, That's your parks, that's your basketball courts, any place where your corners, any place where people would come together. These are your hotspots. But we would lead with education. We would arm our street workers with education and information that they would be able to provide to community members. And Edgar, actually, COIP has historically done such a wonderful job, and I have to commend the work that Dave and his team have done and continue to do. The interesting thing about this is, when you talk about an all hands on deck effort, the North Star is to do what's necessary to rid our communities of this virus, make them healthier, make them safer. And there are many different flavors. There are many different ingredients to this meal, and everybody kind of brings their own flavor to this sort of meal. So this was a document that I presented to the city, and one of the things with working with municipalities is nothing is really easy. It's never like step one, step two, A, B. It's, step one might lead to 1A, 1B, and go back to step one. And, have we thought about, this consideration, and who's going to sign off on this? Who's going to pay for it? Which is usually the biggest, issue that you face. And we had to work through all of those challenges as we work through this. When we initially presented this, and again, I'm going to shout out Dean Giles again for his tireless effort and work and leadership throughout this process. One of the things we had to really sell this to not only the city, but as it evolved, it ended up, we ended up having to sell this, which evolved into our street outreach team that you've heard about, that many of Dave and many of our folks in the School of Public Health are working on. It's being led by Nikki Floyd out of the School of Public Health. But this ultimately evolved into that the street outreach team. So the next sort of what are we doing is just a list, and I'll just talk a little bit about each one because I'm sure you've probably heard of some of them. The UIC Strike Force. That was a university-wide sort of convening, pulling talent, expertise from both sides of campus, the East and West Campus, to address these issues that we see around COVID-19. Well, an interesting thing happened when during this time when we started working with the Strike Force. Well, not an interesting thing, a very unfortunate thing happened. George Floyd. The murder of George Floyd happened as we started to sort of get this group off the ground, and it caused our group, and this group was led by of course, Dr. Forrest is involved, Jenny Hubert Byrne, Jenny Breyer. I think they may have presented to this group in the past, and they've done a wonderful job. But when we started to really ramp this effort up, George Floyd was murdered. And it caused us to pump the brakes and go and look internally and say, well, who are we? Who do we really need to be in this moment, in this historic moment in this nation? And we started to think about the word, well, should we be a strike force? Should we be a task force? Well, when we started to debate that, if you go back to the story I shared with Mayor Lightfoot, being, hey, not a task force, we need a strike force, action. We need to be action oriented. As we all know in academia, sometimes a knee-jerk reaction is to create a task force, and we come up with a bunch of recommendations, and a year or two later, that ends up on a shelf, and then we go back and revisit it. that that is quite a bit in academia. But what we decided we needed to be, who we decided we needed to be, was an action-oriented group that would step in, an open table, so to speak. Folks, bring your gifts to the table, and we respond quickly to issues in the community, not just in the city of Chicago. It became very apparent that as we thought about this, we realized that our capacity as an institution, UIC, actually could be, in many cases, broader than many of our partners that were at the table, and in some cases, even more impactful and broader than even our municipality, the city of Chicago. We started to think about Cook County and the state of Illinois, and how do you demonstrate leadership at that level? So we landed on Strike Force. It's an effort, it's ongoing. I'd encourage any of you to reach out, questions about it, get involved with that effort. The contact tracing, which I know you've heard about, is something that, Brene, there's a researcher, Brene Brown, and she talks about the power of vulnerability. But there's one very specific thing that she talks about that I actually kind of live with on a daily basis. She talks about getting. Thank Dr. Forrest. Perfect. She actually talks about getting in the arena, and getting in the arena and getting your butt kicked. I'll use the nice word, but getting in the arena and getting your butt kicked, right? And that's the only way you sort of you have you make progress. You have these gains. Make yourself vulnerable. And I think in many ways, as we start to talk through these efforts and think about all the wonderful things that are happening around COVID as it relates to UIC, a lot of these things are as a result of us being in the arena. And in some ways, the contact tracing grant is a result of us being really in the arena, swinging, bringing our gifts to the table. The $56 million grant goal will ultimately create 100 new jobs in the city of Chicago. It's probably, it's clearly one of the most transformational types of opportunities that we've seen and have within this crisis. It's interesting how that sort of got how that got started. Again, Dean Giles, we appreciate his leadership. This really came together, and things have moved quick. Things, we talk about being agile. These things move at lightning speed. We had been on a series of calls with the Department of CDPH, Department of Public Health, in our rapid racial equity groups, other subgroups. And so we knew that this grant was coming down the pipe. Well, what we didn't know was that a lot of the way that this thing would probably be written was probably going to be informed by discussions that were already happening. So members of the Chicago Department of Public Health, as they try to figure out what do we need, what does this grant need to look like, what does this RFP need to look like, little did we know they were capturing bits and pieces from everybody at the table, and a lot of that, I'd like to think, hasn't been confirmed, but I like to think a lot of it has been in part due to some of the input that we have offered as an institution, from our strike force, from different members that are part of these teams. So we initially thought that Dean Giles had some ideas around what group we should try to partner with, and for a grant this big, it's about bringing the right team to the table. What most folks don't know is that UIC played a very critical role in establishing that team on the front end. In fact, it was UIC that kind of had the idea of who should be at the table. The team right now is led by the Chicago Cook Workforce Partnership, Chicago Cook Workforce Partnership, UIC School of Public Health, NORC, at the University of Chicago, Malcolm X and SUHE, Sinai Urban Health Institute. I think that's all the partners on that. But we actually got this worked out on a Saturday afternoon into the evening, in determining what that team would look like. And again, we went back to all the lessons that we learned in working in communities, responding with empathy. What does the community need? What are the opportunities here? We need to create jobs. So who do we need to have at the table? We need training. Who's going to handle this and who? So the team sort of came together. We got agreements, worked through some of the challenges and the barriers, and the team came together on a Saturday, and within a day or so, we had a call, and that group was starting to draft sort of a response to this, and we were fortunate enough to win that bid, which is huge for our institution. It's an honor and a privilege to be a part of this contact tracing grant because of the opportunities that it will present for our communities in the future. Perhaps I don't know if I'm freezing there. I think I see my image freezing a bit. Okay, I think it.
Marcus,
Yep.
you know, students have a lot of questions, and I'm wondering if we could break and they could be allowed to ask these questions.
Absolutely.
There's just been this running line of questions as you've been talking, so
Absolutely.
that would be so great.
And you know what, Dr. Force, I can just tell you, this is actually the last slide. I'll tell you this just because it's up. This is one of the sort of outcomes of the work. We created a letter which turned into an ad which ran in the Sun-Times and the Tribune, which named racism as a public health crisis, and we had 36 health institutions around the city of Chicago that signed on. If you have a moment, you can share this at a future time. But look at the commitments that are there from health institutions, including our own. And those are, and again, this is the opportunity that's kind of built into that risk within the community and within working within the communities. That's actually it for me. I'm happy to answer any questions or fill in any gaps.
Go ahead, Angela.
Yep, thank you very much. That was a very interesting presentation. I think I'm going to start off with a quick question just in relation to the public health crisis of racism that you mentioned. So one of the questions that came in was some hospital institutions in the Chicagoland area don't have the best relationship with their communities. So how would you advise the healthcare workers that work in these institutions to approach communication and establishing trust among their patients during the pandemic and the racism epidemic, not to exacerbate the mistrust between the institution and the community?
Well, thank you. That's a very, very good question. And it's not an easy question. That's not an easy answer, so to speak. When this crisis hit, I had a conversation with our CEO of our hospital, Mike Zinn, and it was a very candid conversation around just some of what he deemed some of the challenges that might exist for an institution of our size. How do you respond with empathy to these challenges, to these issues? Angela, I think the best thing that a health worker can do is to be honest. Now is the time to, if there are issues in the field, if there are issues within the organization, bring those issues to leadership. I think the unfortunate set of circumstances in which we are in have created, I think, a very fortunate platform for which folks have now been sort of empowered to ask questions, to bring concerns from the community. I mean, our health workers are folks that are on the front lines and actually are receiving the information and the challenges firsthand. So I think now, now's the time to be bold and keep advocacy at front of mind, and don't be afraid to bring these any challenges back to leadership. Many organizations have created committees that have been developed to respond, to actually capture this feedback. But hold institutions accountable. Hold institutions accountable, and don't let these things just end up on the shelf. So that would be my that would be my suggestion, Angela.
Marcus, this is Dave. I have a question for you. The strike force that's been developed in response to a really urgent public health crisis in these very marginalized communities around the city is important, and I thank you for the leadership and the work that you've done, and a lot of folks here in the school at UIC have done. But I'm curious, how do you feel we're going to leverage this power that is derived from this activism or marshaling folks together to deal with really more entrenched health disparity problems that have been in these communities forever? Diabetes, violence, there's just a ton. But how do you see us leveraging the work that we're doing here to address those other issues?
Well, thank you, Dave, for that question, and I'm going to turn this back on you a bit, and just thank you for your leadership in these and just historic leadership over the years. Dave, I'm hopeful. I'm hopeful that that our institution would not just be a part of the team, but be a leader in this crisis. That's the only way for an institution like UIC, the largest institution in the city of Chicago, with all the resources that we have. I think now's the time for us to demonstrate leadership. I had a conversation with the President Tim Killeen of the University of Illinois system, and I shared just that. And the idea is that not only could we and should we be leaders in research, but we can also be leaders in eradicating systemic racism. So Dave, I think, as my father used to say when I used to play basketball, and he would say, when you're running sprints, I want to see you at the front of the line. If you're not the fastest, then you need to be number 1 or number 2. Dave, the only way, this isn't, we can't stroll through this. We can't be content with just being on the team. Our expectations are higher, and the only way that we live up, we kind of realize that expectation is to demonstrate leadership. It's through leadership.
Edward, do you want to ask a question?
Hey, sorry, my mic was off. I just wanted to also add, to go back to Courtney's question in relationship to like how some hospital system institutions, when they don't have a strong relationship with their community, if you are in that system, and just to kind of echo what Marcus is sharing in relationship to being a leader, take it upon yourself to look to your leadership there and just inquire, like, how do we get to, what system do we have to kind of like ensure that there is a trust, or the mission is incorporating, or looking at what community members' input is. And if there isn't something there, then that is your opportunity that you need to jump on to take your public health experience, take or whatever program you're in, take that experience and say, let's develop something. Let's add something to the system. Let's put our finger on the pulse of why there is this mistrust, or why the community doesn't trust that specific institution or system. So I encourage people. Thank you, Courtney, for that question. I encourage people to take it upon themselves and say, like, this needs to happen, or this needs to be incorporated into the way we run things here in this institution. Because you will be in that situation. You may, wherever you end up after post your education, you will end up in a system where, there isn't an established community trust. Take it upon yourself to lead that effort, or at least drop it on the table of the leadership or the administration of whatever institution you're working in.
So I have one more additional question, Dr. Forrest, if we have time.
Why don't you ask one more, and then maybe we need to wrap it up. Unfortunately, I think we needed 2 hours for this one.
Yeah. So I think this question was directed at the first two speakers, but it would be interesting to hear Marcus's perspective as well. So what has been the community's response to the help you're providing and the different outreach initiatives that you're leading? And what was some key information they have learned in order to be a part of a healthy community?
Maybe I'll try to take a quick stab at it first and let Edgar add. When we first started our initiative out of our field stations around COVID education, I think people, part of it was addressing issues and maybe hesitations people had about COVID, lack of knowledge or information. Clearly some of the myths that Marcus had addressed earlier were some that we had encountered with folks. But after, we've been in these communities for 20, 30 years in some locations. So we've been able to develop relationships with key stakeholders in these communities and gatekeepers. But after gaining kind of their trust and allaying people's fears, people are really open and thankful for this information. Thankful for, one of my field stations in Austin where I was at early on in the COVID epidemic. We were out there early on just letting people know that COVID is a big issue in this community in particular, because as Marcus and had mentioned, people were thinking it wasn't affecting the Black community. We were able to provide information and build awareness, and people were very thankful just for that. That type of information on proper mask use and other types of stuff. So I'll just say people were very grateful for that. We also were able to provide a lot of other address other needs that people had for clothing, food, and other stuff that we've always provided, but people were equally thankful. I don't know if Edgar wants to share, responses he got specific to the street outreach he's done.
Yeah, no, we still encounter individuals that believe this is a lie, or that the administration is trying to kill us all, or they're trying to spy on us, they want to control us. All you can do is, just give them the material, reassure them that this is something that we're going to actively work to solve, and their role in this is significantly important, that their personal beliefs, in some cases, in many cases, misinformation, sometimes they have to take things with a grain of salt. You have to remind, the key thing is to remind them, who do you know, who lives at home? Do you have a grandma at home? Do you have a grandpa at home? Do you have little kids at home? Is there somebody that you know that's ill or has some chronic illness? And that is like, you could see their face, like, whoa, like, yeah. And they walk away from it. You know what? Not in all cases, but if you get one person in a month to just walk away with knowing that, like, whoa, you just gave me something, it's worth it. Even if you saw 10,000 people in a month, and that one person that walks away from you, that's the person that lifts you for the next 10,000 people.
Let me add one last thing, that this pandemic early on began in the context where a lot of organizations that had been providing social services had to close. And we were able to remain open, skeleton crew, not 5 days a week, but 3 days a week at our Austin site. And it was occurring alongside an opioid epidemic. And so we were still able to provide, opioid overdose education, access to food, sandwiches, clothing, and people would say, thank you for being open, because they knew a lot of people weren't able to stay open. So I just wanted to add that.
So I wanted to say a big thank you to all three of you for being with us tonight and sharing this really valuable information. I thought this discussion was very insightful, so thank you. And I'll pass it back over to Dr. Force.
I don't have too much more to say. I think the session speaks for itself. I can't thank you guys enough for presenting to us. I thought that I knew what was going on in the School of Public Health and what UIC was doing out in the community, but I found out a lot of things that I didn't know, and I really appreciate that. Thanks for taking the time, and thanks for hanging in, all you guys. This must have been an interesting class for everyone, because the class actually ends at 6:30 and everybody was still here.
30.
So thanks a lot.
Thank you, Linda.
But thank you. Can I, Dr. Forrest, I know folks are chiming out here, but let me tell you,
Yeah.
I mean, there's 83 leaders on this call, 83 opportunities to demonstrate leadership, and that is, I mean, that's something to get excited about. Every person on this call is going to have an opportunity to go out there and change the world. And I mean, that'll be the expectation. So I'm really excited about this, and thank you for the opportunity to share today and learn.
Thank you.
Thank you.
Bye, everyone.
Bye.
Take care.
Bye, everybody.
Bye.